Most cases of colorectal cancer in sub-Saharan Africa are advanced at presentation. A West African study reported 58% of patients presenting with stage 4 disease, while another 41% presented with stage 3 disease. Multivisceral resections, which involve resection of the primary cancer, coupled with an unblocked resection of parts or the entire adjacent viscous involved through contiguous spread, has been shown to improve survival in patients. Here, we describe the outcomes of multivisceral resection in patients with clinical T4B colorectal cancer. Here, we describe the outcomes of multivisceral resection in patients with clinical T4B colorectal cancer in our unit. We retrospectively reviewed the hospital records of patients of the colorectal surgery unit of Groote Schuur Hospital of the University of Cape Town between January 2008 and December 2013. We identified patients with clinically suspected T4B colon and rectal cancers. Patients with known metastatic disease were excluded. Multivisceral resections were grouped as abdominal wall, urologic, gynecologic, hepatobiliary, and non-contiguous bowel. 494 patients underwent 514 colorectal cancer operations during the period under study. Of these, 158 had clinically suspected T4 disease, and 44 underwent multivisceral resection. 71% of cancers were located in the distal colon. The median age at presentation was 64 years. There was no gender predominance. And although over 60% of patients presented electively, many also presented as emergencies, usually intestinal obstruction and abdominal pain. Furthermore, most patients did not have a family history of bowel cancer. 1 in 5 multivisceral resections involved the abdominal wall, but pelvic structures and the small bowel were also commonly resected. 2/3 of patients had a primary anastomosis. Superficial wound infection was the commonest postoperative complication. At histology, contiguous spread to a resected adjacent structure was confirmed in 37%. Complete resection, R0, was confirmed in 73% of cases. The median survival was 68 months, while 5-year disease-free survival and overall survival were 45% and 55% respectively. Complete resection significantly improved overall survival. However, there was no difference in survival between the colon and the rectum. Pathologic confirmation of contiguous organ involvement was significantly associated with poorer overall survival, although it did not affect the disease-free survival. On multivariate analysis, complete R0 resection was a significant predictor of improved overall survival in both colon and rectum. Tumor spillage and vascular or perineural invasion were significant predictors of poorer overall survival. Long-course radiotherapy (LCRT) was also associated with improved overall survival in rectal cancer. In the rectum, tumor spillage was significantly associated with increased risk of local recurrence. Interestingly, the level of expertise of the surgeon did not significantly affect survival in colonic or high rectal resections. In conclusion, multivisceral resection is feasible in a resource-constrained setting with morbidity and mortality rates comparable to developed countries. Management by a multidisciplinary team should be mandatory. Outcomes appear to be independent of the level of experience, so surgical trainees in the developing world should be exposed to these complex operations during training. A margin-negative resection should be the goal of surgery and results in improved survival. Thank you.